No. Hello there. Here we are back. Hope everybody had a pleasant limited days break and pick up where we left off. Again, just a reminder, you don't have to be here Wednesday morning since I'm not going to be here. I told you all that, right? Enjoy, sleep in, if that's your first class, etc., etc. And all that good stuff. That's first. I will undoubtedly record something. I'm sure it'll be into skin since we're concluding respiratory today. I'm going to pick that up here where we sort of left off. And then I'm going to click back onto the Nestor, pardon me, chapter 21, and see if there's anything else I need to just add to that. I know there's some deep fungal infections on that. Now, we mentioned it in passing here, but I did want to clarify. Now, tuberculosis. The start, like right here, is the most startling factor. I mean, the population of the world is what? Are we 7 billion? Is that a quarter? Probably around a quarter of the people in the world technically have, at the very least, what's called latent tuberculosis. Means they have been exposed to it and it is in them in some way, shape, or form. And what's alarming about that particular statistic is it means the potential is there for this to become highly significant. So again, it's like a lot of other things. And normally our immune system, even if you have been exposed, will keep this in check. But any failure in the immune system, any physical infirmities, any, having to, anything that would weaken your defenses in any way, shape, or form, even over and above the immune system, potentially could trigger it. So, and again, this is what we're seeing. It has become a lot larger problem, probably due to two things: an immense amount of overcrowding, which I think is number one. And you see that in both, particularly China and India and a variety of other Asian areas are particularly overcrowded. And certainly we see a lot of overcrowding in large cities that make this a hotbed. It's just constantly breathing the same air without filtration. As you can see it down, as we get to it shortly, these particles can stay suspended in the air for months. So the difficulty is that recurrent and constant exposure. So very easily infected but resistant to disease. 85% of these cases, it stays in the lungs, which means it's treatable. It is something that will not necessarily cause terrible complications. Okay. And so we're going to look at primary, secondary, a little bit. This is what, if we get to this, primary being infected, when it has become latent, if it, let's say, the best way to describe it, once it's under control either by medication or by your immune system, it can reactivate or be reinfected. That's secondary, that's more problematic. And then this is the worst case scenario, what we call disseminated or extrapulmonary. All it means is that the tuberculosis in your lungs is broken through. We all know your lungs are in intimate contact with your bloodstream. As it breaks through, it releases these horrible bacteria. And really, the way I frame it is like a respiratory, it's like pneumonia that acts like lung cancer almost, because it will spread just like cancer will spread by way of metastasis. Except this is by way of the bloodstream, and it will lodge anywhere, as you will see. That's the frame. Small infectious dose, but don't be mistaken about this. It's close proximity to an area where, think of, I don't want to pick on India, but it's a good way to pick on it. If you ever get a chance to travel there, I remember when my daughter told me she's never seen so many people. I mean, she would see one person with a bicycle and people, 8 people hanging off of it. And it was just, to be kind, she wasn't impressed by the overall hygiene of the country. I'm trying to be kind. She was doing an aid donation in Hyderabad, which is in southern India, and it was shocking to her just how many people were there. Oh, much less if you're fair complected or like the way which she has her hair, which is very good. She's colored. People are coming up and touching her hair because they don't see folks like that. So some of you are in trouble. Get ready for that. Nevertheless, here's what happens. So the tubercle is something that forms. Understand this is a unique bacteria, okay? And what the bacteria is able to do is it actually, even though it's swallowed by a macrophage in your lung, it can't destroy it because of this thick capsule. And what it will do is it will, as it begins to grow in there, eventually it'll change that macrophage. It'll alter the cell. You'll have other cells. This is cell-mediated immunity, okay? T cells that come, activated lymphocytes that come and surround it. They create a giant cell that surrounds it. Unfortunately, they're unable to break it down. And so you get something called a granuloma. Now, granular is because we see granules, a granular appearance, either particularly on, from all the cell nuclei, when we look at a slide after it has been stained. And what happens that, because it surrounds this white blood cell, it causes interesting changes inside. And it undergoes a process called caseation necrosis. What happens is that it forms almost like an oily, foamy kind of consistency in the inside of this hard ball. And so when they recently got its name as a tubercle, remember a tubercle is a bony prominence, something you remember doing in bones in AP1 ages ago. And they felt the lungs and felt these hard lumps. They were calcified tubercles. And calcified of these granulomas said, it must be like a piece of bone in the lung. What did they know? Hence the name. And so here's the calcification, the TB test, because it's delayed reaction, hypersensitivity, cell-mediated immunity. And this is where it can go. It can go not just to lymph nodes, it can go to the kidneys. I've seen it in the bone. It can go into the genital tract, it can go into the brain. Okay. Immunosuppressed patients and young children, and these complications are often fatal. I would even use the word frequently fatal. So they are, and again, the old term for this was called consumption, because it would attack these organs and destroy them. And the people were they died of complications, just frail illnesses. You'll see some of the things that are part of it. Live bacteria remain dormant and reactivate. The tubercles expand in the lungs, drain the bronchial tubes. Very severe. It's green. It looks like it's like a pneumonia type infection in a sense. It's like greenish pus mixed with blood, almost swirling. Okay. And as you're living, the fever is low grade, not because you're not responding, it's because your immune system is having trouble responding to it. Weight loss, just like cancer. Fatigue, again, the night sweats are a giveaway, chest pain. Okay. As you can see, untreated secondary disease, when it reactivates, and if it is either untreated or undertreated, 60% is an amazingly high mortality rate. So you're going to run into it if you're in a clinical field. Even in this country where it's a little less free, it depends on where you are, where you're going. But again, this is roughly 25 years I'm dealing with teaching nursing students, and a lot of them, particularly the non-traditional ones, which were a lot of when I was with Shadyside or CCAC or West Penn, a lot of people worked in healthcare who decided to come back and get their nursing degrees, and they had seen it. They've been affected by it. I cannot tell you how many cases. So it's something you're going to run into, and there's a lot of, this was really when those N95 masks that we all, with COVID, that early on they were using specialized masks. I don't know what the PPE, the personal protective equipment is these days. Many of you will find out. So here it is. Acid fast, you did this, except you used Mycobacterium smegmatum because it mimics it, same thing. Acid fast, mycolic acid, the name of the capsule, very resistant. One of the harder things to deal with routine disinfection. You can see sometimes in AIDS patients, this big cell wall in the capsule and being able to survive within macrophages, strong cell-mediated response. And again, this is one of those things, creating those granulomas is your body's immunological response it's trying to fight it, but since it can't fight it efficiently, it becomes, to some extent, your enemy. It's such an interesting balance. And I was talking to my sister Thursday night, and trying to describe you know, remember we talked in the thyroid and A&P about Graves' disease? She has that. That's like a hyperactive and autoimmune disease of the thyroid. They diagnosed this was much later in life, comparatively speaking. We were having a discussion based on, it's such a fine line, but how do you suppress it and how do you treat it? You'll see what's coming up. It's very, very interesting in regard to that. Droplets suspended in air, 8 months. It's a lot of time. So if somebody at home or somebody in, close quarters in public housing, what we used to call a tenement back in the day. I mean, we have plenty of them here in Pittsburgh. They've been upgraded over time, a long time. Inadequate nutrition, immune, medical care, lung damage, genetics. 60% of U.S. cases are among folks from other countries because they have, unfortunately, I think, again, I underscore it with being living conditions more than anything else. Because we see large families in relatively limited housing because of socioeconomic restraints, financial restraints, work, etc. And obviously where you work. As we're fond of saying, this is the business you have chosen, many of you. You're going to be on the firing lines coming. So TB testing, again, this is called, they're not injecting you, it's a protein derivative. In other words, it's not anything that's going to give you the disease. We just want to trigger the immunological reaction. That's one. This is what happens when we have to find out. When they started me on one of my immunosuppressants, I had to have this kind of a test done before they could start it to make sure I didn't actually have tuberculosis, even though I had tested negative. But that's proof positive. The TB test is very indicative, and then you follow it up with this kind of things. Obviously, if you're going to have to treat it, you have to get antimicrobial susceptibility. And what we did in the lab is a quick snapshot. You get a patient comes in, you get a sputum sample, part of it, culture and sensitivity, and by the way, not just gram stain, but stain for AFB, acid fast bacilli. Limiting exposure, the negative pressure room sucking the air out. This is BCG. It's got, I'll impress you. Biol Calumet Guerin. So I think it's two French doctors named it. Bovine tuberculosis, Mycobacterium bovis. This is what my immunotherapy. We know the immune response. They use this bacteria and put it in you or in me for immunotherapy. And what had happened, and I'm very confident of this, it triggered my immunological arthritis. Precursor was there, the predilection was there, and then boom. So it's powerful. It's bovine tuberculosis. We don't get it, but cows will respond positively to it. And so why we don't use it in the U.S., it renders the TB test, useless. If you're, depending on where you're traveling, like my daughter going to India, in order to get a visa there for whatever the purpose, you have to have that immunization. Period. It works somewhat effectively on children, not on adults. At that point, you always TB test positive. So we have various kinds of treatments. Typically, the treatment for any kind of tuberculosis initially, if it's latent or it's active, 4 to 9 months, maybe a little conservative, probably 6 months or more minimum. Typically more than one, and these are very strong antibiotics. There's different categories of these. You won't have to know them. You may have to know them if you're particularly in nursing and you end up with a TB patient. Believe me, you'll be learning all about it. Okay, non-compliance, it is hard. That is a very difficult regimen. Imagine you have to take 2 different, and they keep changing them on every couple of months. Because resistance. So MDR stands for multiple drug resistant, and you're going to see XDR, extremely drug resistant. So being resistant, at least, so we have multiple, at least isoniazid and rifampin. If those don't work, 18 to 24 months. It's a long time to take antibiotics that have side effects. Okay. Previously treated, worldwide, about 600,000 new cases, 240,000 die annually. This is not an innocent disease. So if you do end up traveling, if you, Doctors Without Borders, that kind of type of thing, where you're going to areas that are underserved like that. Keep this in mind. So are sicker, have a higher mortality with those infected with non-MDR tuberculosis. So it depends on the strain that's there. Even with treatment, about half these people die. Not good. Okay. Okay. So the 9% of these, this is the X, or extremely few treatment options, 70% mortality rate. These are, it's frightening. And basically that's what they have to say about that. I mean, so it's a good way to end this chapter. I did want to go in and take a look at what I had, just because I know there's things I cover. I want to make sure I covered all of them. This is the Lansfield group thing. You should remember it. This is the lady, the whole, what we call it group A, beta hemolytic streptococcus, is that group A, that carbohydrate that's in the cell wall is how that rapid strep test works. Okay, so, and it's a better predictor of its pathogenic capability than hemolysis. The fact that it's beta hemolytic, there's a lot of types of streptococcus, and so that's why you have to identify it as group A beta hemolytic. Okay, that's really important. Streptococcus pyogenes. Okay, and so, as you can see, this is an extraordinarily important individual in the annals of medicine and infectious disease. You can't say enough about that. So here, and again, this is what that throat looks like. Again, we talked about it. This is typically red and inflamed. Again, when you see redness and flame, you see little pustules. Again, we mentioned it before about potentially mono being sort of a look-alike. There's certain things that, and you become to recognize those. We won't go into the physiology of it, or the goblet cells, or the escalator, and blah, blah, blah. All sorts of things are normal. Look what's in your throat, your nose and your throat normally. Yak. So a lot of these things are there. So there's a variety of things. The viridin streptococcus, this alpha hemolytic, that's where the streptococcus pneumoniae that many of us harbor as well. I mean, though you really should not have the beta hemolytic, a lot of us do. So, I mean, there's potential pathogens. Staphylococcus aureus is a major league pathogen in your nose. So we look through a lot of this stuff, the otitis media, and you can read through this. There's nothing really unusually special about this. We're going to do this again in skin because Callan puts this as a surface infection. So with the skin chapter, you'll see this again. To me, pink eye, it depends. I think it's more of a surface infection in kids because they rub their eyes. I think it's in adults, it's much more about upper respiratory. That's me. Being a chronic eye rubber, my wife will smack my hands, threaten to make me wear gloves in the summer. It's like a child. She could give me those little snappy things on my in the winter because I lose my gloves, like the little my mom had. That's me. You never say anything because you're polite. She yells at me because I go out with grease stains on my shirt, even though I washed them. So she has forbidden me. Every now she has to do shirt inspection if she's up in the morning. She goes, "You're just like a little kid." I go, I'm not. Right? It's 3 people smile. Thank you in the back. Brooke's not up yet. She's not yet. What? I can't only wonder what you're looking at. Who your email? Yeah, sure. She's going to send me an email, make it look good. Okay, again, the big players, all of these infections. 1/3 virus, 2/3 bacteria, Haemophilus influenza, gram-negative rod is the amoxicillin story. Strep pneumonia, gram-positive, is encapsulated as the again, encapsulation is a big player in respiratory. Read through that. There you are. That's what a tube looks like. That's the cannula, the little opening that's in there. All of these things are pretty straightforward. This is the strep throat number. Again, look at all this stuff. When we look at a bacteria under, and you saw it before, it is just under a microscope. It doesn't impress you as to what could be there from an electron microscopic. All of these things, clot busters, that's why they're spreading factors. That was so interesting about streptococcal infections that are there. Go through that, and here's the sequelae. The rheumatic fever, okay, involve autoimmune responses. That's what we think about it with rheumatic fever. That's with the heart valve, etc. 3% of severe untreated. We don't see it untreated, but you could see 10 to 20 million cases per year globally. That was 8 years ago. We have the luxury here of availability of, in most areas, of treatment. I mean, you can't spit and not hit an urgent care center anymore. Well, that's, and understand everybody, they're not all created equal, and a lot of them are all about one thing: money. That are there. This is the other one, the kidney we talked about. And I mean, I'm doing this because I know that there are questions test-wise that are in this neck of the woods that are there. Again, we can get this, we'll see more commonly from skin, but certainly can happen here respiratorily. That's that acute post-streptococcal glomerulonephritis. There aren't a whole lot of strains, but they're there. Let me just show you some of this. The diphtheria I talked about. This is the one, remember I was giving you the anecdote. This was a student, so she was probably, gal is a little bit older than the rest of the nursing students, again, in my Shady Side class. So she was probably either a student or a resident right when this happened. So it was quite horrifying. And they call it a pseudomembrane. That's worth noting. It's just like this. The toxin does the damage. And so people can't breathe. And then the toxin isn't done by affecting the heart, the kidney, nerve pain, horrible. This is what it looks like, a little bit there. Again, non-endospore forming gram-positive rod. There's the AB toxins we had talked about previously. Viruses, this is the other thing, the cold we dealt with. I know I mentioned this next one, the adenovirus, a little bit more severe, again, a common cause. They're not all created equal. The recovery is a little bit longer. Lymph nodes, mimic strep throat, other things, again, immunological when we respond to viruses. That gives you the diarrhea, the conjunctivitis. It's just, again, think upper respiratory. That we're there, confused with pneumonia, a little bit longer. It's that we always, I had this bad cold that lasted. Okay, 50 different types, fairly resistant. It's a naked virus, as you can see. Okay. Again, human to human. Years ago, they had talked about, vaccines. This is a recurrent theme with a lot of what we're going to be looking at now. So if you have a pool, whether it's an above ground or whether it's a facility of some type, whether it's a gym, a club, a school, you really have to they are just breeding grounds if they are not adequately treated. I don't love the chemicals, but I like the diseases less. So there's a lot of responsibility with that. Here's the pneumonia. I think we covered those pretty thoroughly. Healthcare acquired versus community acquired. 60% pneumococcus, which is streptococcus pneumonia, or diplococcus. Again, that rust-colored sputum is very much a gram-positive cocci and chains, capsule. That's what it looks like. I mean, that's an immense amount of stuff. So that's all fluid, that cloudy appearance. I mean, it can be a lot of different things. But I mean, if it gets into the bloodstream, again, things in your lungs, as you'll find out, things in your kidneys, because the close proximity, it's very, very easy for them to occur.
How do they not get into your bloodstream more often?
I don't have an answer. I mean, we're talking about how, as long as there's not actual blood damage, most people around here will get them treated. I mean, if you ask me that question in a different country, it's probably because of the inadequacy of care and inadequacy of treatment. Would be me speculating. Short answer is I don't know. But I think they probably get in there more than we think. But as long as your immune system is relatively competent, I don't think it's a major problem. Again, I think it's speculative. So a lot, and the vaccines are there. I mean, again, I think we over vaccine. I never had that. And I think if I had been a smoker, I probably would have been, had stayed as a smoker, I would have had this. Plebs, and you see in the hospital, very, very difficult to treat these days. The sputum gets distinctly reddish color. Now, this doesn't really do it justice. The previous PowerPoint sequence had a better one that was associated with it that are there. Let's see, mycoplasma, so that's walking pneumonia. Interesting. Look, we don't see this so much. It's very tiny. And you just have to, I think, just know a little bit about what it's about. Good chart. There's the whooping cough. We talked about the different stages. Big problem is if the immunization is very effective. Okay. Second, pneumonia due to this or secondary bacterial infections again. Or like this. Again, it talks about this AB toxin. Highly contagious. I just saw that little nugget. Here's the TB. We just went over it. Don't have to do a whole lot with that. Caseation, necrosis. I mean, but somebody's lungs are riddled with this. Real problem. This, again, 8 years ago, 13 million Americans latent, 5 to 10%, a limited amount reactivate. Again, the infectious dose. Well, the same things here. That they talked about the different kinds of blood resistance, the BCG, etc. We did the Legionnaires, which there's a question on in there. Anthrax is mostly a skin disease. The problem is it's endospores. It is very deadly if it's inhaled. The endospores are too large. Why it's a bioterrorism agent? You can, in the laboratory, take the capsule, take the endospore, the outer coating, and shave it down, chemically speaking. And we call that weaponizing, and then you can inhale it. This is nothing new under the sun. I love techno thrillers. Before they had a scare about this right after 9/11, 10 years earlier, I'm reading a textbook about it. I think it was from the same author who wrote the book Coma. I'm trying to remember what it was just, it's crazy. I mean, there's nothing new under the sun with regard to these things. Their anthrax is again, has maybe a distinctive color on certain kinds of agar, not important for us. But the inhalation is much, and this is, people used to get this, they used to call it wool sorter's disease. Now, if somebody's, even though it's mostly automated, if they're shearing sheep, okay, you have personal protective equipment, you have masks. I mean, all of that is stuff that you would have to have. I mean, think of it back in the day when they would be shearing sheep for wool. I mean, they didn't do that. Let's be clear. And so little cuts and nicks on your hands, you would get cutaneous anthrax. It could become respiratory. That could even get into your bloodstream and called respiratory anthrax. Now there, we did the flu at length. Again, knowing the difference between shift and drift is very, very important. It's like a mini review for the final already. Same kind of illustrations that were there. This is, if you didn't hear about it, it's an important question. Maybe I forgot. We don't use aspirin in children. They say 5 to 15. I would be very careful under 18. There are very, very limited indications. If you have life-threatening fever, you might consider using aspirin and Tylenol. That child would already be in ICU. Because aspirin is very effective at lowering fever. But typically these days we use aspirin or ibuprofen. We use Tylenol and ibuprofen. This is an unknown, it's a syndrome. We don't know why. So whether it's chickenpox or anything else, okay, Ray's syndrome, Rye syndrome, very nasty. So the reason I tell you folks, so when people know if you're going to be a nurse or in a clinical field, they'll say, "Oh, Junior's got the flu. What should I use?" Don't just slam dunk and say something. Oh, this product or that product, unless you're sure it doesn't have aspirin. If I get a headache, I take Excedrin. Excedrin has aspirin. Aspirin, acetaminophen, which is Tylenol, and caffeine. Works for me. But Tylenol or ibuprofen, period. The other thing is something called juvenile rheumatoid arthritis. You don't see a lot of it these days. RSV, Again, respiratory disease of the newborn. Croup is what it presents itself in older children. It sounds like whooping cough. It scares you to death. My kids had it, but it's not. It's scary, but not life threatening. Very nasty. I sound like, oh my God. This is a paramyxovirus. It's in the same family as measles and mumps, which we're going to get to measles very shortly. Yeah, I don't know if there isn't a vaccine. We're starting to see more available antiviral agents for this because RSV in adults has become a much larger problem. And this is one of the, this is hantavirus, rodent droppings. Where do we see it? We basically see it in those dry areas where there's lots of areas where you could have it, but where we're seeing it in this country is where there's abundant of dry desert-like conditions, those Four Corners areas, like I talked about before. You're reading about the late actor and his wife, Gene Hackman, brilliant Oscar-winning actor, but they were very, very reclusive at the end. And I guess where they were living was just, oh my God. They went in there, closed the doors, and came back. So I mean, there's a lot of, as you can see, a certain amount of complication with regard to this that are there. We did enough SARS and MERS. These are the COVID-based ones before COVID. This PowerPoint, so it doesn't have a lot of information. This is the lung one. This is coccidio. Okay. Coccidio is valley fever. It used to be called San Joaquin Valley fever. Desert Southwest. If you live there, you know about it. You can get it. Your pets can get it. My brother-in-law lives in Tucson. He and his wife, they've had a dog get it. It's not unusual. People are aware of it. They treat it very quickly and very aggressively, but it's still potentially fatal. Okay. Lots and lots of time. Fever, cough. Once that starts to happen, it's one of the things. Most recover pretty well. Not a lot get the chronic disease. It is potentially fatal. A lot. I mean, whether it was valley fever, whether it was that Bunya virus, that hantavirus fever that we just talked about. Anecdotally, there have been immense amounts of problems associated with that before we had availability of health care, to say the least. This is what it is, coccidioides immitis, fancy name, but the whole idea, thick wall, like a capsule. So inhaling those, and again, they use the term endospores, but they're not, again, don't confuse it. This is a eukaryotic disease forming the same kind of caseation necrosis, fatal without treatment. People who get fungal disease in their lung, unless they're in an area like that, there's got to be something underlying. Yeah, when we see somebody who has never been, why would they have this? Maybe they traveled there, but if there'll be something underlying. We're seeing a lot more of it today because of these underlying immune diseases that are there. Certain dry, dusty seasons can reactivate. So you have to, again, long-time care. And this is the other one, histoplasmosis, because these are particularly for people who go caving, moist areas, certain areas of there's not as frequently as seen here as other areas of the United States. They used to have some other charts that were there. Again, they're all very similar to tuberculosis. Here you go. So see, not so much up here, though we have our fair share of caves that are around, and a lot of people like caving. They're into that. Okay, moist and caving is a bad combination. Bats also. Bats are very, very interesting study for people in science field. They had, my stepdaughter was doing that a lot whenever she went to Allegheny, and I think one of her, I don't know, when she studied a little bit for a semester at Duke and other places like that. One time they were having her go into caves and count bats and stuff like that. Bats are very interesting. Don't think I would do it. And here's the PCP. That's the one that we learned about with AIDS. Again, people who have underlying problems. I think that's it. So I wanted to make sure I covered everything. I think I had a couple of little nuggets that were in there I thought were important. Got that done. Can start skin. Yay, we're starting skin. Can't wait. Yeah, I know you're excited. Skin and eyes. See, immediately they tell you skin and eyes. Okay, I can buy it. We're not going to redo, but it's anything that affects these. You notice, see, to me, the conjunctiva isn't included there. I'll buy that. But skin, hair, nail, these are extraordinarily common. Respiratory diseases, number one. Diseases, and it's not confined to the skin. It's classified by where it appears most frequent. For instance, Lyme disease, the most identifiable thing, and it used to be considered a skin disease because it was a target-shaped rash, a bullseye-shaped rash. You don't always see it, but it's extraordinarily frequent. We now classify it, as it should be, as an immunological disease. I will talk about it here in skin diseases for the sake of completeness. You will see Lyme disease. Just a heads up, it is the most common vector-borne disease, meaning this is, obviously it's from ticks. We are very familiar with it here, but it's just not, it's everywhere. Most common one in the United States. So we have a lot of skin. Differences in thickness vary dramatically. So the thinnest eyelids up here, it's how long you leave stitches in. Top 3 days max. If somebody splits an eyelid and you have to delicately put stitches. Bottom of the foot, 14 to 21 days. Gives you an idea of the parameters. Lower extremity, 10 to 14 days. Upper extremity, 7 to 10 days. Back, 14 to 21 days. We're not going to go over all of this. You already did this in A&P. This is why we call what our prerequisites are about. I don't have to review this. No, I'm not doing sebaceous glands, not. Skin has a lot of inherent defenses. This is immunological. Okay? Negatively charged, positively charged chemicals, salts on your skin. Sodium, particularly. Types of peptides that are there, antimicrobial, okay, acidic, oily, okay, even though lipids, and we have the normal microbes, those are the good guys. They're covering up receptors, there's active competition, and there's more of the normal ones for whatever is available. Toxic byproduct, fatty acid metabolism, inhibit the growth of microorganisms, blah, 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 blah. Those are the, basically, fatty acid, the acid's part of it. Perspiration, acidic, and salt. Lysozyme breaks apart, it kills peptidoglycan, particularly gram-positives that are there. There's a lot of defenses that are there. They'll summarize this. So things that are adapted to dry and salty. Fortunately, the bacteria that are best adapted for that, Staphylococcus. All of our skin, all the time. Most populated areas, this is one of the things that you need to be familiar with. I did it in my lab. Where do we see the most yucky stuff? When we do skin samples, not on the palm of your hand, not on the top of your hand like this, not on your cheek. Where skin rubs against skin, where there's a lot of oily, in the groin, in the underarm area. People with glabrous skins, those folds of skin where skin rubs against it, skin. It's gonna upset you no end when you go into like a hospital and you have a patient and you see all the yuck that's in between people who are really severely overweight. It's just it is. It's unfortunate. When you see someone who obviously has not had good hygiene or not done a good job taking care of himself, don't be judgmental. You don't know what their situation was like. Okay. So I think your initial approach has to be empathetic or sympathetic. I always get those confused. You be kind first. Okay, then once you know what's going on, maybe you can then it's time maybe then you can be a little more in lecture mode. That's me talking to you as people. I think that's just the way I try to approach it. Imagine what you guys have put me through, and I try to be nice. Anybody? Half a smile? Oh, there's trouble in this room. Sydney took the day off. Good. Okay, so look what's there. Everything. Pseudomonas is on the skin. Three most important skin infections, probably in this batting order: Staphylococcus, Streptococcus, Pseudomonas. We'll just get to all of those fungal infections, etc. Okay, hundreds of species, some pathogens, well known. They're there. Different species, different parts of the body. Different people have different species. We know these things. Okay, whatever your typical microbes normal are pretty constant, but it depends on the people. Okay, no. MRSA. As I like to call it, and you'll see my handout on wound infection. Public enemy number one. It is very, very, and that's Staphylococcus aureus. And nowadays, certainly, it's unusual to find ones that are not MRSA. As I said, we've evolved this species a couple of times. Common cause of skin in non-hospitalized people, resistant. I mean, that's community-acquired MRSA versus hospital-acquired MRSA. The difference is the ones in the hospital are yet harder to treat. Very resistant. Gram-positive cocci clusters, no motility, highly virulent, but unfortunately, normal for about a third of us. As I said, in a hospital, if you're working in a hospital at least twice a year, probably 70 to 80% of the folks working, it doesn't have to be nursing staff or doctors. Anybody working there, you can cultivate MRSA in their nose. Doesn't mean they're sick. It means they're a source. Not much you can do about it. Again, maybe what they'll have you do is take some type of, like on a Q-tip, some topical antibiotic that works. Not Neosporin or triple antibiotic don't work. There's a couple of better antibiotics topically. I used to use those a lot topically as well. Remember the mannitol salt agar had 7.5%. Okay, withstands salt. That's why we use salt to grow it, because it is selective. Extremes in pH, high temperatures, viable after drying, very resistant to lots of different things. There. You can't really see it so well. I probably have, that's a typical pustule. So you can start with a little pimple. It gets a white head or a black head. Now magically you'll get a pustule. Maybe it'll be a boil where it gets under the surface and you have to lance it. You can see it's a pustule, but it doesn't want to open up. All of those, they have fancy names historically. There's lots of different names. Raised, red, tender, typically filled with pus. What's pus? Tissue fluid, white blood cells that have been spent, dead bacteria. Don't culture pus. Culture the wound. Wipe out the pus. With a 4x4 or something like that. Occasionally, easily breaks in the skin. You have openings everywhere. You have sweat pores and hair follicles. That's where they form. People with acne, they go in by way of a hair follicle, the bacteria on the skin, which are normal, and secondarily, they have a greater tendency for that pore to clog, and it feeds off the oil and the sebaceous gland, and that's classic acne. It's there. We do see fever associated everywhere. I was at the gym last night. I wiped off the equipment. If you think it's getting rid of MRSA, maybe not. I don't know what's in the little spray cans. Probably the same quaternary ammonium salt they have that they use in a restaurant to clean off the countertop. I don't think it's getting rid of enough MRSA. But if it makes you feel better, if you're at the gym, do it. It looks bad. People give you, the cross-eyed look. They did a Seinfeld on that too. Active MRSA skin lesions should keep them covered to avoid transmission. Seems like a plan. Okay. A lot of times they're hemolytic. Okay. Don't be surprised about this. We did the coagulase test in my lab. So you can see if it makes it solid or you form that big lump that you saw there. Coagulase is diagnosis and species characteristic. That's the distinguishing thing. Very few things when you're looking at Staphylococcus, coagulase is the test to determine between Staph aureus and Staph epidermidis. There's a lot of other tests that you can do. Catalase it does not. Coagulase does. That's a boo-boo. Catalase distinguishes it from Staph epidermidis. Okay. Catalase distinguishes Staph aureus from streptococcal. All staphylococcal organisms are catalase positive. They bubble. Idiot writing the PowerPoint. Okay. Hygiene. Okay. Classic treatment when we have anything that won't open on its own. First, you want it to open naturally. Warm, moist compresses, topical agents, maybe of assistant. Typically, your immune system, think of it this way. Your immune system is pushing from underneath. That's its job. It's creating swelling, it's creating white blood cells who are basically exerting a force to push that to the surface so it will open. Sometimes it needs help. We call that I&D or incision and drainage. It's a go-to treatment. More than one antibiotic, vancomycin is not, again, we went over the laundry list. I don't want to do it again. Typically, little bump diseases, macules are flat. When you say, and this is a description you may end up using, maculopapular, little bumps, flat to little bumps in areas. That's what maculopapular. So when you identify something and you're writing what you've seen clinically, does it have pustules? Does it have little bumps? They're papules. Is it flat? They're macules. Use the right terminology. Okay. We'll get into this kind of things when we talk about flat erase. You're going to talk about measles being part of that. Speaking of measles, we'll stop at measles. I don't want to give everybody the measles yet. I'll talk about that. I'll probably do some of this online, record this, and maybe I'll get it done tomorrow. Thank you very much.
Dr. Stein, I saw your email about the A&P final.
Yes.
So could